Hello everyone, welcome to One Topic a Day. So let's start our topic with one question as usual. Which of the following is not true regarding this? So what do we see here? To know what this is, we have to first identify this organism. What does it look like? It actually looks like a fungus. Yes. So today we'll be discussing about a fungal organism. So let's look at the options. First one is uncontrolled diabetes and prolonged steroid intake are risk factors. Does not affect skin. Amphotericin B, posaconazole are used to treat this condition. So we'll come back after learning this topic and we'll try to answer this question. So yes, I think some of you guessed it, some of you did not. So that is why we are going to explain this entire concept. This is mucor. What we saw here is broad, irregularly branched, rarely septated fungus. So I will enlarge this image. If you can see, I will draw. These are broad based fungi. Their base is broad. Even here, if you can see, it's a broad based. Here it's broad. Everything that you see in this frame are mucor. So all of this are broad based. And they are also termed as ribbon-like. They are also termed as ribbon-like, and they may have rare septations. So if you see aseptate or rare septations, it is mucor. Again, this is another image, broad-based. Here also broad-based, ribbon-like, rarely septate. So I think you can identify it right now. So what is the diameter of these fungus, which is 5 to 50 micrometer in diameter. So going to the next, what are the risk factors? So one of the risk factors that you have to remember is desferoxamine. So in iron overload conditions like hemochromatosis, the patient is susceptible to get mucor infection. Also in diabetic ketoacidosis, steroid intake, hematopoietic stem cell transplantation, AIDS, malnutrition, and in cases of trauma or burns. So one drug that you have to remember is desferoxamine, which causes iron overload, and also we can see it in hemochromatosis. So what are the types of mucormycosis? So the first one is rhino or bitocerebral. So initially it is due to spore inhalation in paranasal sinus, and it causes a blast eschar, also known as necrosis, and it is vascular invasion. It causes vascular invasion and it causes necrosis. So the first type is rhinos or bitocerebral mucor. The second one is pulmonary mucor because the spores get into the bronchioles and alveoli. After that, it is GI mucor, which is due to ingestion. So the first two were due to inhalation. GI mucor is due to ingestion of spores, which causes necrotic ulcer followed by perforation and peritonitis. The next type is cutaneous mucor, which causes indurated cellulitis. So right now we have learned about 4 types of mucor: rhino or bitocerebral, pulmonary mucor, GI mucor, and cutaneous mucor. There are also some more mucormycosis. The other one is rare types, renal mucormycosis and mucor with isolated CNS involvement, which is also via paranasal air sinus. Sometimes this mucor infection will get disseminated in cases of immunocompromised patients. So what is the treatment? It is IV amphotericin B, which is the drug of choice, initial drug of choice. We also give posaconazole, isavuconazole, and surgical debridement to remove the necrotic and the eschar areas. So I hope you understood this topic. Let's try to solve a question for the day. Which of the following is not true regarding this organism? So what is this? We have identified that this is mucor, and so the first one is uncontrolled diabetes and prolonged steroid intake are risk factors. So this is true. Does not affect skin? No, this is wrong. Why? Because there is a type of mucor known as cutaneous mucor. And the third option is amphotericin B, posaconazole are used to treat this condition. This is also right. I hope you understood this small topic. However, it is a very high yield topic. Thank you.